George Smulian is the Ward Bullock Professor of Infectious Diseases, and I'm shortening this, in the Department of Medicine at the University of Cincinnati. And Mark is a Solomon Freehof Professor of Jewish Law at Hebrew Union College, or HUC, in Cincinnati. And he specializes in the literature, Jewish law, and so on and so forth. I'm not gonna go on. And so we're gonna hear 15 minutes or so from George and 15 minutes from Mark, and then maybe a little more longer or shorter, whatever. And then we're going to answer questions. And the way I'm going to deal with the questions is I'm going to go to the chat and just see what questions there are, and I will pose them. I'll take a crack at who they should go to, Mark or George, but they can then shuffle it among themselves as things are appropriate. Are there any questions? Okay, George. Wait, I do want to give well, that's okay. Why don't we go ahead with George, and I'll say what I have to say later.
Mm-hmm. There we go. Okay. I think I'm on. So, welcome everybody. I'm going to spend a few minutes just on a little bit of the science, but mainly more on the current situation here in the region, and then a little bit about the vaccine and where we are and what the future holds for us. So here's just a couple of pretty pictures. You've all seen these many times. One on the right is the classical picture, illustration of the virus with the spike proteins. Shown the photomicrogram on the left shows the halo or the corona, which is how the virus gets its name. So this is the corona around the outside of the virus budding out from a cell. This is where we are at the moment. So this is the state of Ohio, and one can see, looking back here, this was back in May, where we hit about 1,000 patients hospitalized. Things got better in June. July, August, we hit about 1,100 patients hospitalized. And then over the period during October, November, we climbed up to where we've been over the past 2 weeks, which is currently with about 5,100 patients hospitalized in the state of Ohio. You can see that we've plateaued over the last 10 days, but unfortunately we've plateaued at this high level, which is extremely difficult for us to sustain. Here in Greater Cincinnati hospitals, we have about 750 patients with COVID currently admitted, 165 patients in ICU with COVID. I know the UC health system a little better, and so just to give you some of the details from there, we have 34% of all of our admissions at the moment, 35% as of today, of all our admitted patients are COVID positive. And of the ICU patients, 39% today of all ICU beds are occupied by patients with COVID. So almost 40% of all our ICU beds are occupied with patients with COVID. We have 45 patients on ventilators and 7 patients on ECMO, which is bypass, heart-lung bypass machines to try and improve oxygen into their blood flow. So these numbers are clearly straining the hospital system. This is just a view to show you that certainly UC is not the only hospital. This shows you the Mercy systems up the top here, St. E's, Christ, Tri-Health, and UC at the bottom. And one can see over here is the med surge, so the medical beds in these hospitals. The height of the bar is the size of the hospital. The color of the bar represents a percentage of patients, or percentage of those beds that are occupied. And the whole of the Mercy system is running between 95 and 100% occupancy. Many of the other big hospitals, Atrium, most of St. E's hospitals, Christ, all running at greater than 95%. We're a little lower because we've stopped all elective procedures, so we're running between around about 90, 89% is what we were today. On the side over here is showing ICU beds, And one can see that big hospitals with ICU capacity, a majority of these are in the 95 to 100% occupancy at the moment. So we're pretty stretched as regards beds. There's very little capacity. The only places that have capacity tend to be very small hospitals: Butler, McCullough Hyde, Clinton Memorial, Highland District Hospital. So hospitals that firstly have very small capacity and secondly have very limited capabilities as well. Moving forward from the current situation with regards to hospital beds, what are our treatments that we have available for COVID-19 compared to when we last spoke back in May? At that stage, remdesivir was just about to be approved. It's now been in use for about 4 or 5 months. We've used about 500 doses at University Hospital. It's a 5-day infusion for hospitalized patients. It's shown to reduce the length of hospitalization in the controlled studies here in the United States from 13 days to 11 days. It's had no effect on mortality. So there's no data to show that remdesivir actually improves mortality, but it does help free up beds slightly by reducing hospital days from 13 to 11. On the other hand, the World Health Organization has found no benefit in its studies, and it does not recommend its use because of lack of significant benefit. It's relatively expensive, and so World Health Organization does not recommend its use at this point in time. There are a couple of monoclonal antibodies that have been approved recently. There's Regeneron, which is just being rolled out, and there's one called BAMLAM. It's too long a name for me to pronounce, so we just refer to it as BAMLAM. These have emergency use approval, and these are only for non-hospitalized patients, and their role is to prevent admissions. So they're given as an outpatient infusion. The infusion lasts an hour. Patients aren't admitted, but they are done under supervision and then can be released home. And the effect has been shown to be on reducing the need for hospitalization, but not having any effect on mortality at this point in time. Convalescent plasma, or the plasma that's been harvested from somebody who's recovered from COVID, the benefit is unclear. There's better data in milder patients, and the earlier it's used in the course of disease. Once somebody is hospitalized with severe disease, certainly anybody who's requiring ventilation, there's no data to support its use. Most probably the biggest benefit that we've achieved over the past 6 months has been in the use of steroids. These have been good, highly efficacious in reducing death and the need for ventilation. So that the studies all show about a 30% reduction in mortality. And so this is most probably the biggest change that we've seen over the last 6 months in reducing mortality is because of the use of steroids. There's no benefit in patients who don't require supplemental oxygen. So there's no benefit and most probably increased risk in its use in patients who are not needing to be admitted to the hospital. Steroids increase your risk of secondary infections. There are other complications from them, GI bleeding, etc. And so in patients who don't need additional oxygen or don't need to be hospitalized, you're putting people at risk without showing any benefit. What about vaccines? And this is the hot topic at the moment. First vaccines were rolled out in this country at the beginning of this week. Second one hopefully will be approved tomorrow or Friday and will be available for use next week. So there are a number of different ways in which you can deliver vaccine to a cell to be able to stimulate the cell to then, or the body to then produce antibodies and other forms of immunity to clear the virus. The classical vaccines have used inactivated virus, and the inactivated viruses that are currently being developed are mainly ones that have been developed in China. The Sinovac vaccine has actually been approved for use in China and a couple of other countries and is in limited use in those areas. In this country, the 2 vaccines that have received most publicity are the RNA vaccines, where a single strand of RNA is wrapped up in a little lipid particle, lipid fat globule that's then injected into the muscle. It's taken up by cells, and the body then turns that RNA into protein the same way as produces protein from our normal, under normal circumstances from our cellular RNAs. And this leads to the protein, which is then recognized by the host immune system, and antibodies and immune cells are mounted against that. There are also DNA viruses. The Inovio vaccine is developed on that grounds. There's protein subunit viruses. The Sanofi GlaxoSmithKline virus is the one that was in development for that. It's currently being put back a step because the initial data did not show as much benefit as they would like. And then there are a number of other viruses where the parts of the COVID virus are incorporated into another virus which can then infect cells. And these include the AstraZeneca Oxford vaccine, which is under development. This is where we stand at the moment with regards to vaccines, and this is from the New York Times COVID vaccine tracker, which gets updated every day. Very useful site, gives you a lot of details about the vaccines. There are 40 vaccines that are in phase 1 studies, 17 that have made it to phase 2, 15 in phase 3 studies, and 2 have been approved for full use. One is the Pfizer-BioNTech vaccine, which has been approved in the United Kingdom and in Canada and has emergency use approval here in the United States. The other one is the CanSino vaccine, which is a Chinese adenovirus vaccine. Actually, the Sinopharm is the inactivated vaccine that's approved in some countries. The rest of these you can see are in phase 3 or phase 2 studies. So what do we talk about when we talk about study development, drug development, and what are the various phases? So this is standard drug development. There's a long period where science is done looking at what the virus or whatever you're developing your vaccine against, be it a virus, be it a bacteria, be it a cancer cell, or whatever you're developing a vaccine. There's exploratory and preclinical data which is generated in animal models. It then moves to a phase 1 study, which is done in normal volunteers to look for tolerance of that vaccine in normal volunteers. If it's tolerated in normal volunteers, and this is usually a dose-ranging study as well, they try various different doses to see which doses are better tolerated until they find the best tolerated doses. The next stage is a phase 2 study where they now take individuals with disease, looking at some of those doses, the optimal ones that they've identified in limited numbers, looking for safety and tolerance, and then finally into a phase 3 study which looks at efficacy. After this and all this time period, you're looking usually at about 10 years, 8 to 10 years to get to this point in time. It then goes for approval. That approval process usually takes at least a year, and then finally it's released to the public. And for a period afterwards, the manufacturer keeps additional records and to note any side effects or any adverse events which weren't noted in the thousands of people enrolled in the phase 3 studies as you roll it out to millions of people at a later stage. So the entire time period for standard drug development is a 10 to 15 year period. What's happened now in a number of situations, we've developed accelerated drug development situations. This was first done, most probably or most notably done with some of the HIV medications that were brought on. And so here there's overlap between each of the stages. Each of the stages still occur, but they overlap so that the data from one is used to generate the next one, and that next phase is started before the first data is available. So with regards to COVID-19 vaccines, we had exploratory and preclinical data. The exploratory data was largely based on the original SARS virus vaccine development. The preclinical data and the other scientific data was based on vaccine development for things like the RNA vaccines that were developed or have been developed for Zika and for rabies. And so that allowed them to move forward very rapidly with limited preclinical data into a phase 1 study. With limited data, they moved into phase 2 and into phase 3, and then to the FDA for rapid approval. And so this whole time period in the situation of COVID-19 has taken less than 12 months, which is a remarkable achievement. This is the data that we have on the two vaccines, the Pfizer-BioNTech study vaccine, which was presented last week, and the Moderna study, which is being presented tomorrow for discussion. And these are both RNA vaccines that are encapsulated into a lipid particle, injected into the cell takes them up into their ribosome, which is the normal protein factory for the cell. The cell then makes protein under its normal circumstances and then expresses out on its own surface the viral proteins that then elicit an immune response. So if you look at the BioNTech data, and this was in a study that looked at 37,000 individuals, 18,000 of them received placebo and another 18,000 received vaccine. And they looked at a point which was 28 days, efficacy at 28 days, so 7 days after the second booster shot that these individuals received. There were 170 people who then developed infection in these two groups. 162 in the group who received the placebo, so 162 endpoints out of the 18,000. And this was a relatively short period of time, but enough to give us data that we had followed enough people for a long enough period of time to see this big dramatic difference. There were only 8 individuals who got vaccine, so showing a 95% efficacy at this point in time. The Moderna study shows similar data with a 28-day follow-up period between doses, and so 35 days total follow-up of the data that they're presenting. There are 90 individuals in the vaccine arm, in the placebo arm, and 5 infections in the vaccine arm, so 94.5% efficacy between these two. This is from the Pfizer study, and this is absolutely amazing data. This shows you that by day 10, after the initial vaccine, after the first shot, and remember that they looked at it, the data they presented to the FDA was here 28 days, so 21 days and 7 days after the second shot. But already by day 10 after the first vaccine, you can see that the group who got the vaccine no longer were having infections or very few infections thereafter, whereas those who got the placebo continue to get many, many, many infections. And so even after if you look at the total group, those after the first dose and before they even got the second dose, there was already a 50% protection. And if you waited and looked at the group in that next 7 days, it had gone up to 90% and 95% by the end of the 28 days. So this is a dramatically effective vaccine that has rapid efficacy and quickly starts to work and provide protection. What about side effects? And then I'm showing you data here only from the 55 and older age group, recognizing that most of our synagogue members are in this age group, and this is therefore the thing that we're interested in. The top panel here is after the first dose. The bottom panel here is after the second dose, and shown in green is mildest side effects. In blue is moderate. In sort of orange is severe, and in sort of brown is grade 4 with the most severe side effects. And one can see that the most common side effects, and the majority of these being mild to moderate side effects, are pain at the site of injection in about 70% of individuals after either the first or second dose. There was redness and swelling in a smaller group, about 7 to 10% of individuals. Fever in 11% of individuals. Fatigue, headache, and chills. So basically a flu-like illness seen in about up to 50% of individuals after the second dose, but really rate-limiting ones of fever, muscle pains, seen in mild situations in only about 30%. If you look here, for example, at fatigue situations, it was seen in about 20% of people who got the placebo and about twice that in about 50% of individuals who got the vaccine. So many people, even after being injected with saline, are going to feel fatigued. So not everything that one sees is related to the actual vaccine event. How are we going to get it out to everybody? So there are a number of different phases. This is the plan. Phase 1 to high-risk individuals, either as high-risk healthcare workers or people at higher risk for comorbid condition or at high risk for severe disease. Gradually into phase 2, other individuals who are at higher risk for disease or who are going to have a higher impact, such as teachers, critical workers in high-risk situations, into a phase 3 where people with lower risk but who may be important for transmission of the disease, and finally phase 4 to include everybody in the United States. The Ohio development vaccine program is similar with phase 1 where there's limited supply, which is where we currently are at the moment. It's for specific critical populations, healthcare workers and personnel caring for COVID-19 vaccine and for the elderly people. Phase 2 where it starts to open up, and this is still for other critical populations, and phase 3 and 4 where it's available widely. Phase 1, as I mentioned, or 1A, which is where we are at the moment, is healthcare workers, which we rolled out this week, residents at nursing homes, and this in Ohio, 90% of all the vaccine that's shipped this week is going to residents and staff at nursing homes. So of the 97,000 doses that were made available in Ohio this week, 88,000 have gone to nursing homes and nursing home staff members. About 9,000 have gone to hospitals for healthcare workers' use. Who are the people at high risk for developing severe disease? And this is from the CDC's data. These are people who are at increased risk of severe disease, people with underlying cancers, chronic kidney disease, underlying lung disease, heart conditions, severe immunocompromised, the obese, pregnant women, people who are smokers, and diabetics. And how serious is this risk? So this is just looking at age, using the 18 to 29-year-olds, so a healthy group of individuals, and this is the comparison group. If you move up to the 30 to 39-year-old groups, they have twice the risk of hospitalization and 4 times the risk of death compared to the 18 to 30-year-olds. And if you go to people over the age of 85, they have a 13-fold increased risk of hospitalization and a 630-fold risk of death from if they acquire COVID-19. So given the age of our synagogue, we're all at higher risk, or many of us are at higher risk. Many of us fall into the sort of group 50 to older, where we're looking at risk of disease, of death, 30 times higher than a young individual. So even though a young individual may not get severe disease, they can certainly transmit it to many of these populations who are at higher risk. So as cases are rising, we have to do everything we can to protect ourselves until that vaccine is available and rolled out to everybody in this country. Wear a mask, socially distance, avoid crowds, know the bubble that you're in and try not to expand your bubble of individuals, because every time you meet with other individuals, you're expanding your bubble and being exposed to their bubble in addition. And that's more than enough that I've said. With that, I'll hand over to Mark, and it's all yours.
Thank you, George. Very enlightening. Mark, you're up.
Okay, so here we are. Thank you. Thanks, everybody. Happy Hanukkah, 5781. I noticed, in fact, the Lazier's screen, one of their screens, is labeled 5781, which just reminds us it's a relatively new year and a year that has opened, hopefully, certainly compared to 5780, which, let's face it, really sucked because there was a pandemic. Okay, so my task tonight is to run through very, very briefly some of the highlights of Jewish ethics, Jewish law on the subject of immunizations, which is the question of the moment. Specifically, there are two major ethical questions that I want to talk about with respect to immunizations, vaccinations. There can be more, obviously, but the two that I think are on everybody's mind are, number one, the priorities in administering the vaccines, who should get them first, who should have to wait for a while. And the second one, should immunization be mandatory? Should society, should communities make a very strong effort to require vaccinations among those who are medically indicated as being able to accept them without significant risk? So we're going to begin by talking about the foundation of any question having to do with medicine and medical ethics in Jewish law is the mitzvah of medicine, the mitzvah to practice what in Hebrew we call refuah, which is often translated as healing, and now it's a word that means medical practice. One of the classic expressions of this comes from a code of halakhah that emanates from the 14th century in Spain. The code is called the Tur, and it begins by telling us, and the Tur in this case actually is channeling Nachmanides, who lived in the 13th century, so this goes back that far. Nachmanides points out that if you go all the way back to the Talmud, which is, we're talking about the 5th and 6th centuries, we learn from the verse in Exodus 21:19 that we are permitted to practice medicine. That is, that the rabbis, through a process of midrash, interpret that verse in which the word to heal appears twice when it only had to appear once. They said it appears twice in order to tell us that we have permission to practice medicine. Now, why do we need the permission of the Torah, the permission of God, essentially, to practice medicine? The Torah points out that there are two reasons for that. The first reason is that the physician should say, why do I need the tsa'ar in the text, but we can translate that into tsuris? Why do I need all the trouble of facing liability should I kill or injure somebody in the course of medical treatment, right? So the Torah grants you a license. If you know what you're doing, if you're a physician, you can practice medicine. And if bad things happen, if you took proper precautions, you're off the hook, at least formally off the hook for damages that are the unintended and accidental result of medical treatment. The second reason why we need divine permission to practice medicine, the Torah says, is so that the physician not say, well, look, if the Kadosh Baruch Hu has punished someone with disease, which of course in ancient times was the standard explanation for why disease happens, right? God's punishing us because of some sin. Then who am I, the physician, to heal that person through natural medicine and thereby frustrate the divine will? The permit to practice medicine, this license that the Torah grants us, is a way of saying, don't think that way. You're supposed to practice medicine. When people get sick, they're supposed to go to the doctor. Okay, and that brings us back to the preceding slide where we are right now. In this last paragraph, this permission, the Torah tells us, is in fact a mitzvah. It's a commandment. It partakes of the duty to save life. We call that pikuach nefesh, which we know is the highest supreme obligation in Jewish law. It's the one that takes precedence over virtually everything else. One who delays or refuses in the practice of medicine. This applies primarily here to the physician, but as we'll see, it's going to apply to the patient as well. That person is akin to a shedder of blood. It's not technically murder for a doctor to refuse to practice medicine when that doctor knows how to do it, but it's almost the same thing. Okay. Let's see. I think. All right. So now that we know where the commandment to practice medicine comes from, it has to do with. It's a form of the saving of life. It is the way that we normally fulfill the mitzvah of pikuach nefesh. We're ready to turn to a consideration of how we might ethically, in a morally correct way, allocate limited medical resources. If we're talking about drugs, if we're talking about vaccines, if we're talking about physicians and healthcare workers, if we don't have enough to go around, if we're talking about beds in the ICUs, that kind of thing. If our resources are limited and we have to make very difficult rationing decisions, on what basis do we make those decisions? It turns out that the sources of Jewish law provide support for three different ethical theories of how to make these decisions. The first of these theories is what I call strict equality. It's based on the fact that under the Torah, right, we're all created in the image of God. Everyone's blood is equally red. Nobody's life is worth more than anybody else. From that, it would follow that there should be no priorities. The only fair and morally correct way to allocate limited medical resources would be through a lottery or on a first-come, first-served basis, something like that. But we don't make choices. There's no morally acceptable way to make choices. The problem with this principle, of course, is that it's totally unworkable in any kind of society. We want to be able to make intelligent allocation decisions that will benefit the community. And if we're not allowed to do that, if our hands are tied and we have to say, well, first come, first served, or whatever, there are all kinds of ways that can be harmful to the community if we simply withdraw from making any decisions. The second principle, goes really to the other extreme. It's the principle, and this is my name for it, social utility. In this case, we do make intelligent decisions about how to allocate medical resources. We base those decisions on judgments as to which people are more important to the society, to the community, than other people. And those who are more important, who rank higher on the scale of social value, would be correspondingly first in line or sooner in line to get the medical treatment than those who are not that valuable to the community. The problem with this theory is that while you can derive support for it from the sources, it is not well supported in the sources. Most rabbinical decision makers, some of them talk about it, but most of them avoid it. They seem to avoid it because, frankly, again, this is totally unworkable. I mean, it's workable, but you wouldn't want to work it. Making decisions on this basis requires that somebody be in a position of deciding whose blood is redder than whose. And how do you judge is the question. Very few people want to be in that situation, although sometimes we think these choices are fairly easy to make when you're looking at extreme comparisons between people. Most comparisons are not so easy to decide, and it's very hard to justify one group coming before another. When you get into when you get farther and farther into the chain of decision making. So that brings us to the third principle of allocation, which would be you allocate your medical resources on the basis of the allocation that saves the most lives. You deploy your staff, you deploy your medicines in such a way that you save the most lives. That is, in such a way that you're sure, that you're more confident in saving this particular. If you have to judge between two patients, you treat the one you know you can save. That's the triage principle that is familiar from other systems of medical ethics that we know about. Likewise, on a macro social basis, you would say that we would allocate our dollars, we would allocate our resources on the basis of who needs them the most medically, that is, who is in the greatest medical need, who can most benefit from these things medically. The idea being that if we're commanded to save life, we should try to do that as effectively as possible. We should want to save more lives rather than fewer lives. And so we would allocate on that basis. This is the solution, or the theory that has the most support in the sources, particularly among rabbinical decision makers across the board, across the denominational board who have dealt with these issues. But it's not free of problems. We're not always able to decide whether a decision, to know whether a particular decision is truly a medical decision, or maybe we're making a decision based on socioeconomic grounds that is masking as a medical decision. It is not free from difficulty, but if we have to pick a principle from Jewish law, we would say that the one that has the most support is you allocate based on the number of lives you can save, the more the better. Now, what about that second ethical question, the question of compulsory medical treatment? You remember that slide that George showed us, showing the state of Ohio's allocation priorities regimen for the vaccine. It was emphasized several times on that slide that the next, people in this group will get access to the vaccine if they choose to take it, right? Whoever designed that system wants to make sure that we're not going to force anybody to take the vaccine. But there are different ways of approaching the question of compulsion. It's one thing to say the state is not going to send the vaccine police to your house and make you accept the immunization. On the other hand, institutions, public and private institutions, can make rules about who gets to come in, who gets to go to school, who gets to go to synagogue or church, who gets to go to a concert or go into shopping malls. If you don't have the vaccine, or if you don't have an official exemption on medical grounds, we might not let you in. That is a form of compulsion. So the question for us is, what does Jewish law and tradition say about this? Here's how we go at it. On this slide, we begin with the statement from the Shulchan Aruch, a very familiar principle in Jewish law that says that in a case of potential danger to life, pikuach nefesh is involved. A physician says, hey, you've got to take this, you've got to accept this remedy, this drug, this procedure, whatever it is. A patient needs to accept that remedy. Now, if you got other physicians say, no, you don't have to, maybe the patient doesn't have to, but let's say one physician says you got to, another physician says, no, you don't have to. The patient should accept that remedy, even though it involves a transgression against Shabbat. You would have to break Shabbat in order to administer this particular procedure. And the reason that's significant, of course, is that the violation of Shabbat, chilul Shabbat, in traditional Jewish law is taken extremely seriously. It's punishable by death if you do it on purpose, according to classical Jewish law. So it's an extraordinarily serious thing, but you're allowed to do it, you're required to do it if the particular thing that you have to do is connected to providing medical treatment to someone in danger. Now, on the basis of that, the Magen Avraham, who is a commentator on this part of the Shulchan Aruch, concludes, well, okay, if the patient does not want to accept the remedy, he is compelled to take it, right? If it's okay to violate Shabbos in order to give it to that person, then if that person says, nah, I don't want it, maybe I'm trying to be pious, or maybe I don't think, I'm not in such a bad condition, no, that you've got to take this thing, and we can force it on you if we can. At least we're permitted to do it. So, is medical treatment compulsory under Jewish law? Yes, it is. Now, that brings up an important distinction that we find in the writings of Rabbi Yaakov Emden, who lives in the 18th century. He points out, he's not the first one to do this, but he's the one that really says it the most clearly, the first one to say it so clearly. He points out that there is an important difference between two types of medical treatment, two types of refuah. There is the refuah that he calls vada'it or beduka, or tested or proven therapy. That is a drug or a procedure that, according to medical opinion, is effective and proper and will achieve the result that we want it to achieve, or certainly it is the one that we always administer in a case like this, even though it may not always work. As opposed to untested, controversial, what we today would call experimental treatments, which have not yet been proven, which have not yet been tested. A patient must accept treatment that is tested and proven. A patient does not have to accept treatments that are not tested and not proven, treatments that are experimental. Now, that makes perfect sense. The question for Rabbi Yaakov Emden was, well, who decides? He's not altogether clear on the question of who decides. At one point he says, well, it's the physician. On the other point he says, well, the patient has something to say about that. Pointing out that we're not always certain as to the efficacy of medical treatment. And so there is a role for individual choice, which is important to us because we live in a world where patient autonomy and individual choice are sacred aspects of the medical ethical, of our approach to medical ethics. The traditional Jewish approach minimizes the choice of the individual. It is much quicker to conclude that particular medical treatments are compulsory, that you have to accept them. Most rabbis who have spoken to the issue of the coronavirus vaccines with any degree of specificity have said, that, a vaccine with 90 to 95% efficacy falls into the category of tested or proven therapy. And therefore, based on the logic of these sources, it would be mandatory for individuals to accept the vaccine, and institutions then would be on good grounds to deny entrance to folks who, without a good medical reason for an exception, refuse to take the vaccine. That, of course, is not where the issue stops in America or in any other country today. But I think that I'm going to stop here because I think we've covered the bases here.
Thank you very much, Mark, both you and George. It's a really nice counterbalance to what we've heard. It's very, very interesting. Okay, so I'm going to go through and take a look in the chat and start giving some questions. Is that okay? Or does that work for people? Any objections to that? Okay, let's. Well, this is not necessarily important, but it's amusing. Ben Carson reported, this came from Arnie Horowitz, reported that after contracting COVID, he took an extract of oleander. What can you say about that?
My only comment as regards to that is that in South Africa, oleander bushes were occasionally people would cut down the branches and make skewers for their barbecues, for skewering their chicken or whatever it might be, and it's highly poisonous. Every year we would see people dying from their barbecue because of the oleander extract that they got from the woods. So I certainly would not want to take an extract of oleander.
It is like bleach. It's the same thing. Okay, anyway.
Okay, here's one which I'm sure a lot of people are thinking about. Is there any issue in taking a first jab of Pfizer and then the second one of Moderna, or vice versa?
So yes, even though they're both vaccines that are derived in the same manner, they both have the same RNA in them, but the lipid around them, the little particle that they packaged in, is different. And so therefore there's no studies that have looked at whether one gives you the effect of the other if used independently. So the current recommendation is you should only stick with the same brand that you got the first time around.
Okay. Somebody, Sonia Milrod, asked, I've heard Johnson & Johnson vaccine will be out in January. Which approach does it use?
It's an adenovirus vaccine, similar to the AstraZeneca vaccine.
Okay. The difference between that and the Moderna?
So the Moderna and the Pfizer are RNA vaccines where your body's cell is making the protein. The adenovirus vaccines are you in putting that same piece of DNA into the adenovirus. That adenovirus is then doing its normal function, which is infecting cells and then cohorting the cell's mechanism to make protein as well. But it's the way in how it gets in and the molecule in which that's injected that is different.
Okay, you answered this, George, in your presentation, but I'm not sure if somebody, Mike Seidman, wants to know timing standpoint. When will older multiple medical issues can expect the vaccine to be available?
Most probably February, March, I would think.
Okay.
They're meant to be 20 million doses rolled out during the month of December, but those include first and second doses, so 10 million individuals, which most probably will cover nursing home residents and many of the healthcare workers, the rest of healthcare workers, most probably getting it in January, and then other high-risk individuals, January, February.
Okay, thank you. Mike Seidemann again. How long can we expect to be wearing masks, social distancing, avoiding crowds, etc.?
So from a point of view of transmission, you need to reduce transmission. You're most probably looking at developing herd immunity. So you need about 60 to 70% of the population to be immune. So looking at the United States, about 200 million, between 200 and 250 million individuals to be immune. We've already had 15 million individuals who've known to have contracted the disease, and that's thought to most probably represent at least 4 or 5 times that, so about 60 to 75 million individuals who actually have contracted it, and the others we're just not aware of. So we most probably have to administer about 100 million doses of the vaccine until we get to the point where we're impacting transmission.
This may have been answered, I'm not recalling, is once you've had the vaccine, how long is the immunity to it?
We don't know. Okay. Because we haven't, the first people who got the vaccine only got it 4 or 5 months ago. They got it in July. And so we know from July until now, but we don't know anything beyond that.
Okay.
They still have good immunity at this stage.
Okay, this is one for Mark. If you can benefit more medically according to the Jewish canon, can you decline in favor of giving it to another who will benefit less?
Technically, you shouldn't. I mean, there's the famous, the classic example that we find in the Talmud. The story of two travelers wandering in the desert. One of them is holding a canteen of water. If that person drinks all the water, he can reach the next town. If he shares the water with his companion, there's not enough water for both of them to reach the next town. They're both going to die. What do you do? There's a dispute among the rabbis about this, two opinions. The first is share the water, right? Because you're both equal and neither one of you should cause the other person to be mistreated. And the second opinion is no, the person who has the water should keep it because, and there's a theory that reaches that, but essentially we know that your duty to save life, first of all, save the life you can save, and secondly, you are in possession of the water, so the needle swings to you. Interestingly enough, there is no rabbinical opinion registered in the Talmud or in the commentaries afterwards, which suggests that somehow it's a mitzvah for the one who has the water to give it to the other traveler, which would be a lovely act of self-sacrifice, and we would consider that to be noble. But put the nobility aside, what you've done in handing the water to the other person, what you've done is say, just ethically speaking, you said that your blood is redder than mine, right? I can't take the water away from you. If I happen to have the water, that's the status quo ante, we would say. That's just the way things were. I'm not making a choice. But if I give the water to you, I'm saying that your life is somehow more worthy of being saved than mine, and that there is no Jewish ethical warrant for that. Even though in some circumstances, clearly we would admire people who do such a thing. We certainly admire people who assume risk to save other people's lives. In this particular case, this would be committing suicide in order to save somebody else's life, which from a God's eye perspective, it's a wash. It's one life or the other, and we really can't decide which one is more worthy of being saved.
Okay. This probably goes to Mark again. Comment on the super spread events of the Orthodox community in Brooklyn.
They shouldn't have done it.
I'm glad it's you.
Both
all I can say about that sort of thing is that obviously there is a journey to be made from ethical principles, moral principles, legal principles, and the world, the real life situations to which they need to be applied. The world is complex. We're dealing with people who have all kinds, because of the communities in which they live, the traditions in which they partake. Some find it difficult, if next to impossible, for all kinds of reasons, to practice the sort of social distancing that we all need to practice. Now, what they ought to do, what everybody ought to do, is ask themselves, do we really have to do this? And I don't know, I'm not a Hasid, or I don't live in Borough Park or Williamsburg, but it seems to me that if I were to ask myself that question, the answer would be no, we don't need to do this before we receive the vaccines. But the world in which we live is a complicated place. We've got people who seriously distrust the institutions of government, of science, of medicine, of business, and so forth, and they don't want to follow the rules, and they should. And we have to. We're going to have to take into account the fact that they probably won't, not without some degree of persuasion, coercive or otherwise.
Thank you. This is from Rini Roth, a question I'd expect her to ask. George, have you gotten your vaccine yet?
I actually was lucky enough to get my vaccine this afternoon. And I'll tell you a little bit about the decision, how the decision tree went at university, at UC, just because it's informative. So we got 975 doses of vaccine. What we had done last week is we had looked at, of the 13,000 employees that we have at UC, how many of them are patient-facing and how many of them are deemed high impact employees, critical employees. And so we had about 1,800 to 2,000 employees who fell into that category. We divided them up into what their functions were. There were, for example, 10% physicians working in critical care and pulmonary in the emergency room, etc. There were 50% of them were nurses. There were 10% of them who cleaners down in the emergency room. And we divided up the number of vaccines in the same proportion as those proportions of the 2,000. And so physicians were not rated any higher than the cleaners down in the emergency room. And in each of those groups, it was they opened up a sign-up sheet and it was first come, first served in each of those groups, so that there was some sort of social utility, some form of, equity to make sure that physicians weren't rated higher than anybody else. But it was the best we could come up with the limited amounts that were available. Luckily, we'll get another batch of 3,000 doses on next week if the Moderna vaccine is approved, and that will allow us to vaccinate all those essential workers and the next group of high-risk individuals.
Okay, thank you. You didn't have any side effects yet, I assume.
Not yet. I haven't grown a third arm.
Barry Wolfson, what longitudinal studies are being conducted?
So all the studies that were enrolled patients require all individuals who receive vaccine and the placebo arms, because those are likely will get given vaccine sometime in the new year, to be followed for at least 2 years to monitor for safety. And as with all other new drugs, there's a post-marketing phase as well, so that the 100 million doses that will be administered, there's a database to collect any side effect data from each individual under those circumstances as well.
Okay.
Katie had a question just while I saw it in the chat there. The vaccine itself is free of charge to everybody in this country, or will be free of charge to everybody in this country. There is an administration fee which is allowed to be charged, but most providers at this stage in all public health environments have agreed to waiver that to anybody who does not have insurance that would pay it, so therefore there'll be no cost to anybody who does not have insurance for receiving the vaccine.
Oh yeah, that's a question that I had, and Ray just gave it to me too, and there was somebody else. Should a person who had the virus get the injection, the vaccine? That's your question.
So the answer is yes. We know from the preliminary data that after natural infection, immunity wanes. If we're looking at collecting convalescent serum, for example, after about 2 to 3 months, immunity has waned to the level that we can't collect serum from those individuals. At this stage, from the individuals who got the vaccine, there appears as if the immunity is being maintained for longer and higher levels after vaccination. So we're recommending everybody even if you've had it, go ahead and get it. At the same time, while things are scarce, because we know that immunity after infection most probably gives you a reasonable protection from at least 2 months, I would recommend, for equality and for access, the people who've had it recently perhaps delay getting their shot for the next month or 2 months, or after they've had infection, and to allow that to be given to somebody else.
Okay, let's see. Oh yeah, this is, please clarify the difference between authorizing a vaccine and approving it.
So the emergency use authorization is based on the fact that we know efficacy, we know limited safety data, we know the safety data, firstly, immediate side effects, as you saw in that study, that slide that I showed, the side effects immediately afterwards or for a short period during the study time, the 28 days that these vaccine data was presented to the FDA. That's enough to give authorization. Full approval will only come at the completion of these studies, so most probably take 2 years before full approval is given.
Okay, thank you. This is Joe Zukar. I understand there's a vaccine coming that only needs one injection and doesn't require extreme cold temperatures. Is that true?
So the AstraZeneca vaccine is a single shot as opposed to the 2 shots of the current 2 vaccines that have been presented. The Pfizer vaccine requires to be stored at minus 80 degrees, can only be stored at room temperature or at least cold 4 degrees in a refrigerator for 5 days after reconstitution. The Moderna vaccine is stored at minus 20, so routine, the same as your freezer in your refrigerator, but can be stored for 30 days in a refrigerated temperature. The AstraZeneca vaccine, which is a single shot, does not require refrigeration more than a standard refrigerator. So most probably will have much greater utility in the third world and other areas where freezing is much more problematic.
Thank you. This is another one from Vic Amster. How long and they may be covering, some of these may be covering answers that were given. How long does it take for the vaccine to give you the immunity?
So as I showed you in that slide, you start to see the 2 lines diverging by about day 10. The data that was presented was after 7 days after the second dose, so day 28 or day 35. And at that point, it was 95% effective. But you start to see benefit already after about 2 weeks after receiving the administration.
Okay. I have a question. At what stage of development is the nasal spray vaccine? That's from Sandy Spitz.
So most of the nasal spray vaccines that have been previously used have been live virus vaccines. And clearly this is not a virus that we want to use live virus vaccine, even an inactivated, attenuated vaccine, an attenuated virus. So at this point in time, there are no nasal viral vaccines that are in advanced development at this point.
Okay, I have a question. What cocktail of medicines was given to the president so that he recovered so quickly?
So he received the Regeneron monoclonal antibody cocktail, which are a number of 3 different antibodies that are against the surface proteins of the virus. And the Regeneron data has not been fully presented out in public yet. The other one is the Lilly one, which is in a similar manner. It's a single monoclonal antibody as opposed to the cocktail. It's called the BAM-LAM one, which was approved about 3 weeks ago now. Shows some benefit and certainly benefit in preventing admission.
Okay, we have a question from somebody called iPad. How did they know that the people in phase 3 were actually exposed to the virus so that they were able to decide that the vaccine is 95% effective?
Of the 18,000 or the 36,000 in the Pfizer study, of the 30,000 in the Moderna study, the question wasn't how many were exposed, but how many actually developed COVID infection. So the 170 that I showed you in the Pfizer study, the 162 in the placebo arm, and the 8 in the vaccine arm, all developed clinical COVID. So those people obviously were exposed after the vaccine to develop clinical disease. How many of the other 30,000 were exposed, we have no idea.
Okay, I'm looking for some questions that haven't been answered yet. Oh, well, this is one from Barry Wolfson. It's from Mark. How do we justify giving, this may have been answered, giving vaccines to political or religious leaders first?
If it's me, then we don't need to justify. Well, let me actually, I want to, before I get to that question, we'll go back to something that George said when talking about his own vaccination and how they at UC that they made that determination. It's widely accepted that among the first people to get the vaccines will be physicians and other healthcare workers who are on the front lines treating COVID patients. Along with the physicians, you have to think about everybody in the medical delivery system. The nurses, obviously, the techs, the people that do the cleaning, because all of those individuals are vital to keeping those institutions going, institutions that provide medical treatment. So this is not a social utility criterion, it's a medical criterion. In order to administer care to people, you need to have healthy people, or you preserve the health of the people who are doing that. Once you make that determination, and then you don't have enough vaccines at the moment to go around for everybody in that category, notice that George said, well, it was a first come, first served basis. At that point, everyone who falls within that category is equal to everybody else, and then the principle of strict equality appropriately plays a role. If you're going to immunize politicians, religious leaders, I guess professional athletes, because look, the NBA is starting up soon, and we all want that to happen. When I said earlier that the easiest principle to justify in terms of allocation is a medical principle, I had that in mind. If you can justify the decision, as hard as it is to make these decisions, if you can justify it on medical grounds, it is much easier for the community as a whole to live with that decision than if you can't. In other words, you have to really stretch to say that politicians, now by politicians, do you mean the president? Do you mean the Joint Chiefs of Staff? Do you mean people who are part of the critical infrastructure of the country? Those are easier decisions perhaps than members of the local city council, something like that. But the farther away you get from a strictly medical criterion, the harder it is to justify. You can try. You can try. I mean, that's we're in the realm of argument here, so make an argument. But I don't think the argument will not be as effective as it would be if you could say, well, this person needs to be here to, let's say, oversee the rollout of the vaccines and oversee the delivery of vital services to the country while we're recovering from the pandemic. Okay, you can. That comes closer to the medical saving lives criterion than other sorts of principles, other sorts of criteria.
Okay, with a number of new questions have come in. This is from Royal. Once you have the vaccine, can you still be a spreader of COVID?
We don't know that answer. The studies have looked at protection for clinical disease. They have not looked at whether any of the individuals who received the vaccine still carry the virus and whether they're able to spread that virus. But they're looking at, or they've looked at the endpoint that they studied in this, and the data that was presented to the FDA is clinical endpoints of episodes of COVID infection.
Okay. So answer is we don't know yet.
Yeah.
Okay. A question from Sonia Milrod. If those that have had active COVID should eventually get the vaccine because their immunity is limited, then a great many more vaccinations will be needed to achieve herd immunity, correct? Question mark. If so, when do you think it will be safe for us older folks to travel within the US and outside the US?
Unfortunately, we don't know enough about immunity from this virus yet. It's a relatively new virus. We know that, for example, SARS had lifelong immunity. Even though antibodies levels dropped, the protection appeared to be lifelong. If you look at MERS, the other serious coronavirus infection, immunity faded after 2 to 3 months. If you look at seasonal coronaviruses, there's partial protection for a 2 to 3 year period after exposure. Unfortunately, there are many different seasonal coronaviruses, and so we can get lots of different ones because the protection's only somebody So we don't, even though I say that antibodies drop down over a period of 2 to 3 months, we don't know that that means that somebody who's naturally infected has no immunity. And so we, ideally everybody in this country who can get vaccinated should be vaccinated, and should be vaccinated as rapidly as possible. I think that when we start to get into that herd immunity phase, even if it's only for a period of time, will impact transmission and reduce, and the pandemic will gradually burn itself out based on lack of transmission, even if we if we don't have full immunity.
Okay.
So I can't give you a definite time period, but most probably looking at summer next year, it would be reasonable to think about traveling, by which stage a significant proportion, and overseas most probably later next year, but those are speculations. Don't quote me on those at this point.
Okay. Let's see. So Sonia's written that down so she can distribute it. Anyway, this is from Judy Miller. Many people are making decisions on what to do and not to do based on risk-reward thought processes. It's not an all or nothing situation. Is there a halachic basis for this?
I don't think anything is all or nothing. We're all making these decisions all the time, unless you're like me, you've spent much of your time the last 9 months underneath your bed. I mean, most of us are going out and doing the things we have to do. We go to grocery stores. We go to our jobs if we can't work from home. So it's really not, for the vast majority of people, an all or nothing situation. Like most things in life, it's a question of balancing important goods, as ethicists would say. That is, ends that are important and good and desirable. What is more important? All we can say is that every decision you make about, well, how do I balance risk or reward? You should think about what the risk really is, the risk to yourself, the risk to others, should you contract the disease and then spread it. And if you consider that and take it as seriously as you should, you'll be closer to all than you are to nothing on that scale. And the closer you are to all than to nothing, obviously the safer you are. It's just, life requires that we make decisions like this. Here, what ethics, what halakhah can give us in cases like this are principles and rules of thumb to help us make more intelligent decisions than less intelligent ones. And if we do that responsibly, then we've gone a long way to doing what we're supposed to do.
Thank you.
And I think that from a medical point of view, think about all of the measures that we do at the moment. No one measure is 100% effective. The only measure is, as Mark says, is staying under your bed for the next 9 months and you'll starve to death. It's, but in all seriousness, wearing a mask is most probably has a 70% efficacy. Social distancing itself has about a 50 to 70% efficacy. Avoiding other individuals, crowds of unknown people have an efficacy. So all of these together add up to give you a greater degree of thing. At this point in time, and certainly for the next period of time, the vaccine just has to be viewed as another level of protection that you're using it. It's not going to replace any of these other measures. It's just one additional measure. And obviously, if that pushes you up from 80% protection to 95% protection, then that allows you a little bit more freedom to be able to balance those risk versus benefit ratios.
Okay, this is from Carol Lake. Do we know why some people develop post-COVID syndrome and others do not? What factors lead to someone becoming a long hauler or not? Thanks for this opportunity and a valuable, informative and valuable opportunity.
Unfortunately, we know that most people who get ill and who get severely ill, it's not the virus that causes the severe illness, but rather the host inflammatory response. It's your body fighting the virus and your body not knowing when to turn off its fight against the virus that causes the problem. And that immune reaction varies from individual to individual. Why do some people get sick and some people who get the same amount of virus do not? And those are most probably genetic factors. And those are the same genetic factors, or some of those same genetic factors impact the difference in whether somebody clears a virus, becomes a long hauler, or develops post-viral syndromes.
Okay. Let's see, this flipped.
Complex way of saying no, we don't know.
Yes, gathered that. This is having a good vaccine creates an ethics problem with the placebo group in clinical trials and will lead to additional vaccines being tested against proven vaccines. It's 9:19, Mark, if you want to.
Okay, yeah, all right. So if I'm sure this question, both of us can answer it. I'll go first.
Okay.
Medicine, the way you look at this, I think, is that you start with this premise: medicine is a mitzvah. To practice this art or science we call healing is a mitzvah. Well, what is medicine? Medicine today, anyway, is a science that is based on experimentation. This is the way we develop remedies, drugs, the procedures that we use to fight disease and to preserve health. And the way that experiments are conducted, the way the tests for the vaccine are conducted, the only way that you can determine whether a particular vaccine is going to be effective and safe is to use placebo groups. If there were other ways to do it, then we would. But if this is the way that we can be sure, then the use of the administering of a placebo is part of a process which itself is permissible, indeed even required, in order to advance the cause of medicine and the performance of the mitzvah. Clearly, we have a duty to people who get placebos and then perhaps contract the disease after that. But that's a duty of care for them, but the fact that they were part of an experiment in which X number of people were going to get the drug and X number of people were going to get the placebo, that's the way the process works. And, so it, by definition, it's part of an ethically permissible procedure that leads to the development of life-saving drugs.
Okay. George, did you have anything on that one?
Yeah, from a point of view of the discussion within the scientific community, the FDA recommendation last week for the Pfizer study was, in fact, to continue the placebo arm for the full duration of the study. So to keep a long-term placebo arm to show to allow better data on the safety of the vaccine compared to the placebo. The discussion that's been going on this past week among many different medical groups is that that's most probably not ethical, and that at some point in the most probably not too far distant future, that the studies will be unblinded. Everybody will be followed for long-term safety, but the studies will be unblinded, are likely to be unblinded, and that the placebo group will receive vaccine because most people in the science community feel it would be unethical to continue and withhold the vaccine from that group, given the efficacy and the impact of the disease.
Okay. We may have had this one and I'm not recalling. Do you assume that once you've been vaccinated, you can't get the virus again?
We don't know that answer.
This may be the second time you're saying that to that question. Okay, Mike Scheffler, do we know how long aerosolized virus remains infective in the air, an aerosol?
So aerosols are a minor component of the transmission of this virus. Large droplets are the major components of the droplet of transmission of this disease. Aerosols do remain, when aerosols are generated, they can remain under, depending on the ventilation conditions, for periods of time of many minutes up to hours in an area. But they are not the major form of transmission. Even things like singing, shouting, those sorts of things are more aerosol generating than regular activities, but aerosols still remain an uncommon mode of transmission of this disease.
Okay. This is from Barry Wilson. Ethically permissible if participation is option and not coerced.
I think Barry's referring to the what we're talking about, the administering of placebos to some participants in these experiments. In general, yes, it's certainly it's a principle of our Western medical ethics that that nothing should be coerced. You'll remember in the Jewish sources, the medical care itself is it may be mandatory. Nobody will come right out and say that participation in an experiment, let's say, is coerced. But there are times when, for example, when emergency responders are testing new methods of resuscitation, that when they arrive in an emergency case, they need to resuscitate an individual, and they will try out the new method. Obviously, this person cannot consent to this. They're not in a position to consent to receiving this experimental form of resuscitation rather than the one that is generally used. And the point is, of course, that if you see that this new method is not working, you quickly go back to the accepted method, because your first duty is to that individual as a patient. So there are times when and the justification for doing this without the express written consent of the patient is that this is the only way we can test this particular procedure. Otherwise, we can't figure out a way to do it. If we could, without violating the rule of consent, then we would. Just as if we could get reliable findings without going the route of placebo, half the people get placebos, the other half get the drug. Obviously, it would be better to give everybody the drug. It's you have to measure the benefits. You measure that against the effectiveness of the study, which would lead to the development of the vaccine or whatever it is you're testing.
Mark, I was thinking of two things when I said that. One is our unfortunate history of testing things on prisoners or minorities or people with disabilities. Mm-hmm. And the other one is our current system where we coerce people to participate in tests by paying them money.
Well, talking about our experience, the Jewish people have a very recent historical experience of being subjects to gruesome medical experiments You know, one might say, you know, in our past gives us reason to be suspicious of the medical establishment. The members of the Black community in the United States are talking about this a great deal themselves. They have also good reason to be suspicious based on their experience with regard to the medical establishment. And so what you do with this, and obviously these experiments, the Tuskegee experiments, the Mengele experiments, of course they were unethical. The question for the rest of us, and it's a real live issue, and it shouldn't be swept under the rug by some principle, is how do you talk to people who are suspicious, who are resistant, who just refuse to accept this vaccine, knowing that if the number of those people rises to a certain level, then the attainment of herd immunity will be called into question. I mean, we need a certain proportion of the population, you know, to take this vaccine, and we really want to get these folks to agree. We're not in a position, again, to directly force them to do it. We are in a position to use various incentives. You know, you can't do this, you can't do that unless you're immunized, in order to encourage them to do it. But we have to remember that, you know, we need to talk to them. We're facing an emergency, and we're not in a mood to have long conversations about things with people who believe in conspiracy theories and all of that. But there are enough of them out there that we need to do everything we can to open up real communication with them, so as to avoid the more gruesome kinds of coercion, or the more objectionable kinds of coercion that we might feel we have to resort to. That's reality. That you know, those of us who let's say are in a position to be more trusting of expertise, of medical expertise, and other kinds of expertise, you know, should remember that not everybody is in that position, and we need to at least try to communicate with them and persuade, as opposed to just assuming they're going to knuckle under to the regime. I mean, there's going to be resistance. We just have to take that into account.
Okay, I think we've been going for a while, and we should wind up and thank Mark and George for participating. I am going to put my email address into the chat, and so if you have any issues, then any questions, whatever, please give me a call, and I can forward things from that you send over to Mark and George and get answers as would be. Thank everybody for participating.